I'd like to thank all the speakers. So we're going to start with the questions, and we have a couple of questions for Dr. Alford. So the first two questions are kind of related, and they're how long do you leave the bolster in place? And once you remove it, do you remove the sheath, or is it absorbed?
No, the sheet stays there indefinitely. It just becomes absorbed. I do the bolster for 2 weeks, and if it's an area where a bolster doesn't really seem to be effective, I keep it patched for 2 weeks. One of the problems is you can't wash this area off. You don't want to wash the sheet or the powder in that first 2 weeks. Now, after 2 weeks, it's sealed in there so much, it's almost like a scar, like a clot, and it's okay. So bolster or covered continuously for 2 weeks.
Okay, third question for you is, what do you have the patients apply to the skin after you remove the bolster? How do you...
So after the bolster, I usually use erythromycin or gentamicin ointment twice a day. And usually I do that for 2 more weeks.
Okay.
Just to keep it moist and promote that healing.
Now, I have a couple of questions for you. So I've had some limited experience with Matristem and Matricel.
Yeah.
My results are not as good as in your case. So I'm wondering, are you debriding the wound before you apply the product, or you apply it straight on the charred site?
I'm not doing debridement as such, but if the patient comes in from the Mohs surgeon office, when I take the patch off, I prep it with betadine. So there's probably a little bit of debridement that goes on, but usually I'm repairing these within the first few hours after Mohs surgery.
All right. So it's not important to have any blood, any fresh blood on the bed?
I don't think so. The thought of healing is the clot is the first stage of healing, and that blood starts to stimulate the healing process. First it's clotting with fibrin and those factors, and then you have the inflammatory response. So I don't think it's going to get there.
Okay. And in one of the cases you presented, I think you apply it directly on the bone. Is that true? Can you do that?
Yeah, and of course in the literature in neurosurgery cases and degloving, scalp degloving, they're using it on the bone, and it works. Okay, it doesn't look quite like it looks on this periocular skin, but yeah, you can apply it directly to the bone.
All right.
But most of those that you saw that look really good, that has some orbicularis or some muscle or soft tissue underneath.
And then in the case where you did repeat preauricular skin graft removal, so it looks like it healed to a line instead of a patch. How do you explain that?
Gosh, I've been thinking about that. Nobody's really done that. I just assume that as it's healing and remodeling, it's just doing it faster with this product in place. And I think that's just the last area where the collagen just bunches together. That's all I can think of.
Okay.
But
right.
that's a very dramatic use, because if you're taking big skin grafts like that, it sure is nice just to put that in there in 1 minute or 2 and move on, as opposed to trying to close and undermine that. And in a patient like with ichthyosis or some serious damage, it's just almost impossible to close those.
And now, last question for you: have you had any bad results with this procedure?
No allergic reactions, no infections or rejections, but I think it's limited really to areas where there's not a lot of skin tension. So think of it like what areas would you, if you could, would you let it granulate? Would you let it heal by second intent? And that's where this really works. I don't think it's as effective on the lower lid. I don't think I would use it as the anterior lamella, for like a cicatricial ectropion.
Okay.
I just don't think it's effective for that.
Excellent, thank you. Now, a few questions for Dr. Barmettler. What do you think is the cause of middle canthal tendon laxity to start with?
What's the cause?
Right.
I usually tell patients it's birthdays. What do you tell them?
Like one of the people in the audience wonders if it's rubbing the eye, allergies, wiping, vigorous wiping. Would that contribute? Do you counsel them to avoid those behaviors?
I counsel everyone to avoid those behaviors, but I haven't specifically noticed people with floppy eyelid syndrome having more medial canthal laxity. Have you guys seen that?
That was one of the conditions that I was thinking of when he mentioned it, and I think rubbing definitely can contribute. And most of the floppy eyelid syndrome patients, you'll notice that they sleep on that involved side, and so we can have them protect that. And most people won't listen, though, when you tell them to not rub their eye. If it's filling up with mucus and it's irritated, they'll continue to rub it. At least in my experience, it hasn't worked.
Yeah.
Another question is, what level do you actually anchor the suture to the periosteum? Is it the posterolacrimal crest? Is it deeper in the orbit? And where do you come out with the needle? At what level do you come out when you come out? It wasn't clear from the video where you come out with the needle.
I think that when you're actually in that area, there's not so much space to play around with. So I think as long as you get any periosteum along that posterior lacrimal crest and a good bite where, I always show the resident, oh, look, you can make their head move. That's kind of my gaze if you've taken a big enough bite. This is a little bit related to the last topic for the last session, but someone was asking, what can you do when you're doing an endoscopic endoscopic DCR, and the bone is too thick to use a kerrison? I found that using a sonopet is actually fantastic in that area, because the drill, sometimes you have to be thinking about the rotation of the drill, the entire length of the drill, so that can cause damage to the nose inside. So the sonopet is a nice way around that.
Also, have you noticed any risk of strangulation of the lacrimal sac with this procedure?
Yeah, you can definitely do that and that's why I think it's really important that you don't just yank that suture down and tie it as tight as possible. You have to take a look at the shape of the eyelid, but I think that's similar to the lateral tarsal strip, where if you tie it really down, you're gonna have that sort of the same effect as a belt on a sort of larger, I keep talking about larger men, but a tight belt on a larger man, if you just make it really tight, it's going to go under his belly, right? And so I think the same holds here.
Thank you. And for Mark, what is your maximum? Sorry, Mark Lucarelli. What's the maximum time you wait before you repair it the most effect?
It's very common for us, for difficult lesions, that we want paraffin fixed permanent sections before we close them. So on something like a Merkel cell or sebaceous cell, very common for us to wait for 4 days or up to a week. I will say in some of the cases with melanoma in situ, where you're not sure how many layers it's going to take to finally get clear, we've had weeks where we've been waiting for Mohs to finish the job. And so I say in general, 4 days to a week, and it hasn't seemed to result in a problem. And it's very unpleasant for the patient to be open longer than that, but we've had to see that happen on occasion, usually in melanoma in situ.
Now, another question. We all know that Mohs is not 100%, and there are certain areas like the medial canthus where it's particularly more likely to fail. Now, do you do any biopsies after the Mohs procedure deeper into the orbit or from the bone before you do a reconstruction?
Yeah, that's a great question. So in the slow Mohs or modified Mohs that I was referring to, of course, the advantage of Mohs is to look at 100% of the margin, to look at the entire surface. But on some of those lesions, tumors where there may be skip lesions or higher risk for recurrence, that's where the slow part comes in, because they'll take an extra safety margin around their conventional Mohs and send that as paraffin fixed. And then the other, you asked about bone exposure. Mohs or any other of the techniques, you really lose the margin if it's down to the bone. And so in those situations, communication with Mohs is to what did the margin look like on your specimen, and then if there is bone exposure, sometimes we'll drill that area with a high-speed drill and just burr away, a 1.5 millimeters, 2 millimeters of bone, maybe not 2 millimeters, but a cushion of bone to clear that into some fresh tissue that wouldn't be invaded by a basal cell or something.
Right. Right. Another option would be cryotherapy, using a cryoprobe to freeze thaw a couple of times. And last question for you: are you ever concerned with flap or graft tension and survival because of tension? And do you ever use hyperbaric oxygen?
Yes to the first. Basically, always concerned with the flap tension, because if the flap's under too much tension, your blood flow through the flap is going to be could be compromised. So having a sufficiently large flap that is not under excessive tension is, I think, one of the basic principles of a good reconstruction. I have not used hyperbaric oxygen, but I suppose if a large facial flap was in the process of failing at that first post-op visit, that might be a role for hyperbaric.